Dr. John McArdle, Clinical Assistant Professor of Medicine in the Pulmonary Division and attending physician at Hartford Hospital, is here to talk about evaluation of the respiratory tract. Hello, nice to see you.
Nice meeting you.
I'd like to ask you several questions that are pertinent to your examination. And the first is, for evaluating the upper tract, I know you take considerable care in that, and it's a reminder to our students that respiratory examination does not begin and end with the lungs. Is it desirable to evaluate sinus transillumination in a darkened room?
Yes, it is, because very often the ambient light will impair your ability to see normal transillumination in the oral cavity, and so it's generally most useful to do that in a darkened room.
Although, of course, for purpose of our demonstration, we may not show that because we don't want to fade to black on the camera.
Correct.
For years, it's been taught that the chest radiograph may remain normal in the first day or two of pneumonia when crackles are available on pulmonary auscultation. And it's often been taught as a victory for physical diagnosis, as though physical diagnosis were at war with technology rather than complementary technology. What is your experience with that phenomenon?
It's fairly frequent that you'll see a patient who has a fever, purulent sputum production, and crackles on exam, and you'll get a radiograph that doesn't clearly define any intrapulmonary pathology. What we'll often do in that setting is treat the patient as though they have pneumonia. I have yet to see, in my experience, an X-ray subsequently reveal a pneumonia after the initial X-ray was negative. However, in a number of cases, we've seen patients who have subsequently gone on to get CAT scans in that setting who may have basilar infiltrates or infiltrates at the sulcus of the diaphragm, which were otherwise not accessible to the plain radiograph.
Thank you so much. I'm looking forward to watching your pulmonary exam.
You're quite welcome. Good afternoon, sir.
Good afternoon.
I'm Dr. McArdle, and I'm just here to perform a respiratory examination on you. If you just relax and as you are and breathe comfortably, okay?
Okay.
Now, when I perform a respiratory examination, I like to start from the head and head downward, essentially, and go through all the major organ systems that have significant impact on the lungs. So where I start initially is up at the eyes, and the things that I will look for would be any evidence of pallor in the conjunctiva. So you just pull the conjunctiva down and have a look at them. And that's to ascertain whether or not anemia or any blood abnormalities might contribute to a patient's sense of dyspnea. Subsequently, it's always also very important to just have a good look at the patient's eyes and assess for any evidence of abnormalities in the eyelids, any evidence of ptosis, because as you know, ptosis and pupillary irregularities are sometimes associated with intrathoracic neoplasms. There's a Horner's sign where patients will have a ptosis and meiosis of the ipsilateral pupil, which is in the setting of interruption of the cervical chain, the cervical sympathetic chain, which can sometimes be caused by an intrathoracic neoplasm. So after the cursory review of the eyes, I'd like to have a good look in the patient's nose. Could I have you lie back for me, sir? And the reason behind this is that a lot of intrapulmonary pathology, such as asthma or emphysema or other vasculitic disorders, are often accompanied with pathology in the nasal tree. And with an otoscope or nasal speculum, you can visualize the inferior and middle turbinates and look for any ulcerations of the nasal mucosa that might go along with some of the aforementioned problems. Likewise, palpation or percussion over the maxillary or frontal sinuses can be used in an effort to elicit tenderness or abnormal sensations in the sinus cavities. Oral exam is also very important in patients in whom you suspect intrapulmonary pathology, as a number of different vasculitic disorders and pulmonary neoplasms are also seen in patients who have higher risks of oral neoplasms or ulcerations in the oral mucosa. I'm just going to have a peek alongside your teeth, sir, and open your mouth wide. Say ah.
Ah.
Again, ah.
Ah.
Okay. And I see no evidence on his exam for abnormalities of that sort. Next, I'd like to proceed to the neck. I'm just going to flex your neck up and down. Just make sure that everything moves around well. Just assessing for normal motion of the cervical spine. And then there's a series of different lymph node chains that it's important to palpate. And start with the submental nodes just under the chin. Follow with the submandibular nodes. And then the anterior cervical and posterior cervical chains, as well as the supraclavicular chains, which will often drain intrapulmonary neoplasms up into the supraclavicular area. I'm just going to have you turn your neck to the side, if you will. It's also often important in patients with significant lung disease to assess their jugular venous pressure, as intrapulmonary pathology such as emphysema or pulmonary fibrosis will often lead to right heart dysfunction and subsequent elevation of the jugular venous pressure. Now, it's important to try and distinguish between the jugular venous pressure waveform and the carotid pulsation. The jugular venous waveform has a far greater excursion with respiration than does the carotid pulsation, which should be unaffected by the patient's respiration. Likewise, you can alter the patient's jugular venous pressure just by pressing at the base of the neck to impede inflow into the chest. And I do not see any engorgement in John's jugular veins. I'm just going to lift your chin, sir, and have a good look at your trachea. You always want to examine the trachea for midline position. You place your thumbs alongside the trachea, and can I have you bend your chin up a little bit further and just take some nice deep breaths. And as he's breathing comfortably, you want to assess whether there's any evidence of what we call a tracheal tug, whether the trachea is actually impinged by something in the thorax and gets tugged downward as he breathes, and his trachea does not get tugged while he breathes. Likewise, you want to assess for midline position of the trachea, because conditions that cause a shrinking of one side of the thoracic cavity will pull the trachea towards the ipsilateral side. So a condition such as severe lobar atelectasis, if he were to have a bronchogenic carcinoma obstructing his left mainstem bronchus, his entire hemithorax may collapse due to lack of aeration, and his trachea might be pulled over towards that side. You also might see in the setting of a tension pneumothorax, where the contralateral chest fills up with air and the mediastinal structures get pushed away from the side of the pathology, the trachea might deviate away from that area. And so it's a useful sign assessing outside the chest cavity for any evidence of intrapulmonary pathology. Now, before I get to his chest itself, I'm just going to examine his nails, and what I want to look for is any evidence of clubbing. What you want to look for in the patient's nail beds is how brisk his capillary refill is, whether there's any evidence of cyanosis. The normal nail beds are somewhat pink in color. A bluish or a purplish hue would be suggestive of a very low oxygen level. You also want to look at the contour of the nail itself, because clubbing will very often lead to a rounded appearance to the nails. Now, not at all infrequently, patients will have a rounded appearance to their nails just as a normal variation. And one way that you can distinguish between that and pure clubbing is to ask the patient to actually put their thumbs or their fingers together and look for a space between their thumbs and fingers, if you could do that, sir. So it's not at all uncommon for some patients to have roundish appearing fingernails, and in order to distinguish that from true clubbing, it's often useful to have the patient put their first knuckle together and put their fingernails together. And in the non-clubbed patient, you should be able to see a space here. That's known as Shamrock sign. In the clubbed patient, you would see the fingernails together and diverge at the tip in the setting of true clubbing. And so you can see this nice space here between John's two fingernails that show that there's no clubbing present. And so John's nails are normal in appearance, a nice pink hue with good capillary refill and no clubbing. While I'm down on his arm, I'll go ahead and place the blood pressure cuff. And what I want to test for here is the presence of a pulsus paradox. Now, the way I measure a pulsus paradox is I very slowly raise the blood pressure until no sounds are audible. And then I very gradually release the blood pressure cuff until I hear the first sounds. And then I greatly restrict the speed at which the needle